Good afternoon or good morning, depending on what time zone you are, and welcome everyone. But I'm delighted to welcome you to today's Spotlight Series webinar. Merci beaucoup pour nous avoir joints aujourd'hui. And today's Spotlight Series webinar is focusing on a hugely important topic for all of us. It's focusing on what are we learning in terms of pandemic recovery and response, and particularly the people who provide care, the core of our health system, and how do we address and respond to their needs. A friendly reminder that l'interprétation française est disponible pour cette session. Veuillez sélectionner français or French dans le menu d'interprétation pour écouter en français. To begin today, I would like to begin by recognizing and acknowledging that I personally am joining from traditional unceded Algonquin territory in the place that we now call Ottawa. And I'm so fortunate to live, work, and play in this space that as I've learned more about traditions in this area, I've learned that it's a traditional meeting place, a traditional place of learning, of exchange of ideas and new knowledge. And hopefully in some small way today, but in a different electronic virtual way, we can continue some of those traditions, recognizing the many territories on which everyone is joining with us today from coast to coast to coast, lands that have been walked by Indigenous peoples since the beginning. And I invite you to pop into the chat and introduce yourself. And if you can include the territorial land acknowledgement there as well to join us in this larger virtual circle here today. With that, it's my pleasure to get us started. So maybe all of our panelists can turn on their cameras because we are about to join our full panel today for today's Spotlight Series discussion. And we have a great panel. I've been looking forward to this for weeks. And when we had a pre-meeting, I was so excited about the conversation we had then. So I'm really looking forward to continuing it today. We have three amazing panelists joining us today for this conversation. Christina Kraus, maybe you can wave, Christina, because our names aren't showing up, who's joining us from the West Coast, so still morning, Christina's time, as CEO of the BC Patient Safety and Quality Council. And then moving across the country, we've got Scott Malcolm, who is a brand new title, just promoted. Congrats, Scott, to Brigadier General. I had to write that down. I'm not very good with ranks, but congratulations on your new promotion, Scott. Looking forward to you joining our conversation as well. And rounding out our panel, Julian Kernahan. I'm delighted to have you joining us today, Julian, bringing a perspective of that CEO of an organization and, oh my goodness, the challenges that we've seen over the last few months, but also that looking forward and the compassionate leadership perspectives that we're going to need to keep in mind going forward. So I think we've got thanks for waving, Jillian, so everyone knows who's who, three amazing perspectives for our conversation today. And we're going to start with a lightning round. So each of our panelists has a chance to introduce themselves in a little bit more detail than I just did and lay the table in terms of where they're coming from for today's conversation that really, as I said at the beginning, focuses on the heart of healthcare and the people who are involved in that care. So Christina, can I invite you to start us off on our lightning round?
Great, thank you so much, Jen, and it's great to be here. My name is Christina Kraus. I am the CEO of the BC Patient Safety Quality Council. I am joining you today from the traditional unceded territory of the Tecumseh people here in Kamloops, British Columbia, where we can see our mountains today, which is exciting for us after having had many days of heavy smoke from forest fires. So I'm thinking of many of the people around who are experiencing forest fires. We've had a devastating loss here in British Columbia recently with one of our communities, Lytton, being over 90% lost. And as you also are probably likely aware, we had the unmarked graves of 215 children here in Kamloops who were identified on the Kamloops residential school grounds. So, it's there's a lot going on in the world today, certainly here in Canada. And I think, after COVID and what we've been having there, but now to have hope from COVID and hopefully coming out of this pandemic and what the vaccinations have offered us. But as we then start to, I think somebody was saying to me the other day, when will it end? We had this absolutely bizarre heat dome here. We hit 47.3 was our highest temperature, but we had 4 or 5 days over 46 degrees here in Kamloops. After having, this recent discovery, we now are into forest fires. There's also flooding risk, and COVID is still present. So, for me, as I think about quality and just a personal interest area, has always been about how do we set the right context in which for us to work to be successful, to provide good care for our patients and families. And we know that energy and the energy we bring to work, but also the energy within the organization makes a significant difference in our ability to do that. So that's the conversation that I'm looking forward to today, and just grateful to Healthcare Excellence Canada for bringing me into that. So I'll hand it back to you, Jen.
Thanks so much, Christina. And thank you for starting that laying of the table with the realities that are around us as well, because we all live our whole lives, don't we? We're not just one piece of those lives and need to bring them all to the table as well. Scott, do you want to go next?
Thanks very much, Jennifer. And thanks to everybody for the opportunity to speak here today with such a wonderful group of Canadian health leaders. I, like Jennifer, am coming to you from the unceded territories in Ottawa, and certainly my heart, my thoughts go out to our Indigenous colleagues and really our Indigenous populations, as Christina highlighted, with all the tragedy that we've been experiencing and with the unmarked graves in the residential schools, and certainly to Christina and the team out in BC with their challenges. In my new role that I've just taken on, I am now responsible for the day-to-day running of our healthcare system in Canada, often referred to as the 14th healthcare system in Canada. And that includes providing support to domestic operations as we did in the pandemic, but also looking to provide support potentially to the BC wildfires and also to the floods in the Yukon. So I'm also looking to hear the words of wisdom from Dr. Kernahan, because for all intents and purposes, I'm sort of taking on a CEO role in this new job as well. As of late in this new role, my focus is really going to be on planning what recovery and reconstitution is going to look like. I think we've heard these terms tossed around a bit, and I've come to realize that the recovery aspect is very much going to occur at an individual level and may actually be very difficult for us to define as leaders. And I think this is where that compassionate leadership piece is going to be critical, because we're going to need to hear the needs of our individuals and do our best to respond to them. On the topic of reconstitution, which is perhaps a term that's a bit used a bit more frequently on the military side, we're sort of seeing this as more of an organizational type approach. And it's often thought of in terms of restocking equipment and other things. But I think we can all appreciate, given all of the challenges that our health workforce has been through over the last year, that there's a requirement to reconstitute our health workforce as well, either folks that have moved on or are considering moving on, and really saying, how are we going to accomplish this? So these are the two pieces for me. How do I build some space within the organization to allow some recovery, and so that we can look to reconstitute and draw other folks into the workforce. And some of the things we're looking at in terms of trying to achieve that are really through optimizing the scopes of practice of of all of our care providers, and with a focus really on use of least scarce resources. And it's something that we were able to accomplish through the pandemic, most notably in our response to long-term care facilities, where if we had relied solely on physicians, we would have come up very short. But in fact, we're able to deploy our medical technicians, our dental technicians, our dentists, our nurses, our preventive medicine technicians, really looked to all folks with clinical backgrounds who could go in to do that and really optimize and maximize our ability to deploy. And so ultimately, we've taken really a needs-based health workforce planning approach to the pandemic, and it's allowed us to gain some ground, and I think establish that this is something that we want to do moving forward. And with that, we've had recognition from within the Canadian Armed Forces of what we've done over this period. Obviously, we've messaged this a lot, that the stress and strain that this has put on us. But what I think it's going to afford us is a bit of space to carry on, allow for that recovery to occur. And with that, there's going to be an opportunity to change some old ways as well. And one of the things that we're looking to use to capture that is a person-partnered care approach, and one where we're looking to empower and build trust across, for us, the three parties involved in care, which is the chain of command, the patients, and the clinician. So again, I look forward to the opportunity to answer some questions, share this wonderful platform with these great leaders, and thank you once again for the opportunity to speak today.
Thanks so much, Scott. Really appreciate that. Julian, round us out. You've got a whole range of perspectives to bring to this conversation.
Thank you, Jennifer. My name is Julian Kernahan, and I come to you from London, Ontario, which is the traditional territory of the Atawandron, Anishinaabe, Haudenosaunee, and Lunapeka. I'm sure I said that wrong. Peoples who have long-standing relationships with this land. London sadly became quite famous internationally with a recent tragic event with our Muslim community, and it has really left a mark in our community, as we have sadly got notoriety as a result of that event, and that's been a very recent event in our city. My role is President and CEO of an academic 4-hospital system in London, Ontario, and neighbouring communities. But we also run a 400-bed long-term care facility, as well as a number of outreach and outpatient services across the region. During the pandemic, I had the pleasure of providing regional leadership to our region. We have 24 hospitals in the region and 78 long-term care homes, so provided leadership for the pandemic response across the hospital system and the long-term care system. It was a humbling but rewarding role, as I watched people come together and work together in ways that, although we had relationships before, we developed very strong, responsive relationships. And a WhatsApp group got a response in about 5 minutes from all the CEOs across the region to say, how can I help? And that was actually a very wonderful thing to see. Through the 3 phases of the pandemic, it required really changing our leadership structure across the region to respond appropriately to the challenges, because every wave really had its unique challenge and its unique impact, both on the people we serve and the people who serve in our organization and across the region. And I think that's what's the most important learning for me, is that everybody has had a different experience. I think of even our own organization. We had people who cared for people at the front line who had COVID. We had many people who were redeployed to all different parts of the organization to support, including our long-term care home, where we redeployed about 60 people to make sure we didn't have some of the disasters that Scott and his team had to respond to. We had people redeployed to parts of the organization they've never worked in before and had to adjust to that. And also we had leaders who basically have been on call 24/7 for months and months and months and months. And although staff were able to go home at the end of the shift, leaders really were never off, and recognizing the challenges that they have faced over the last several months. And I balance that out with the experience of the people we serve. So our patients, residents, clients, whatever part of our organization we refer them to, they experienced it very differently. across our organization, as well as things were closed and then opened and then closed again, and their procedures or surgeries were delayed. Our family caregivers experienced it very differently. My husband is a patient in our long-term care facility, having lived with Alzheimer's for 12 years. And so I didn't get to see him for months because visitors were banned in our own organization. And we worked hard to get back once we were allowed to by policy, and have really focused on our essential caregivers being an integral part of wave 2 and wave 3. So lots of different experiences through the pandemic. And the privilege of working with lots of different people who responded with great heart to the needs of this particular challenge that we faced over the last 15 to 16 months. So looking forward to that conversation.
Thanks so much, Julian, and lots of threads in the conversation that I'm really looking forward to diving into. I'll also, just as we start diving in, invite those, because I know some people have joined a little bit later, feel free to introduce yourself in the chat so everyone knows who's on the line. And if you've got questions or comments at any point, you can also pop them into the chat. That's where we'll be taking questions from the Q&A. But I have the luxury as moderator of the panel of starting with some of my own questions. It's a little bit unfair, but there you go. And Christina, I'm wondering if I can start off with you, because I know you and the council have been addressing the questions of organizational energy that you spoke about in your introduction for a while now, definitely pre-pandemic. And you've been thinking a lot about pacing over these next phases. I'm wondering if you can talk a little bit about that. Oh, you're just on mute.
Oh, I did the thing that you're not supposed to do. But I think, as I was reflecting, even during wave 1, and, each of the waves from an energy standpoint were quite different. Wave 1, the number of our cases wasn't actually that high. And I've heard some people say, well, we weren't seeing a lot of patients in the system. So it wasn't, the workload wasn't heavy, but the reality is the fear of unknown, the trying to sort out the PPE, trying to determine what we needed to do without a lot of information actually was a significant energy sapper. So, the pull on the energy sources that happened to people was just coming from a different place rather than a traditional workload of seeing patients. And as we came out of wave 1 and went into wave 2, what was interesting for me is that for many of us, at least here in British Columbia, the focus then became on a restart and catch up on the care that we didn't provide during wave 1. So while I think a lot of the public had a bit of a reprieve from COVID last summer, people sort of were able to do a bit more things, and it was a bit of a break from the pandemic. The people who were working in the system did not, because we had that. And then we went into wave 2. We had more information, we had more knowledge, but the volume was greater. And then we had a little bit of excitement from vaccines were coming, and then wave 3 hit, which, as many of you know, was certainly the biggest. And I think, by then we were well over a year into this. And a couple of things strikes me in that we know that if we try to be productive for too long without purposeful rest, there's a consequence to that. And that consequence is typically burnout. And we had burnout experienced in our system pre-pandemic. So we went into the pandemic with many staff who were already feeling in that space. And burnout can happen from a number of reasons. It can come from the type of work we do. It's not just always I'm working long hours or I didn't get my rest time. If there's a number of sources of energy that we know fuel us, from sense of purpose in the work that you're doing, from the content of the work that you're doing. Do you enjoy it? Are you challenged by that? We also know that intellectual energy is a source, social energy, feeling connected to people. And I heard a lot of that, just by being behind masks, in staff rooms, not being able to gather in ways that we lost that social energy, which was a fuel source for us to do our work. So we took away some of those fuel sources, but then also had a heavy workload. And the consequence to that can be great. And, often when people think about rest and recovery, they focus on Are people getting their vacation time? Are they working long hours? Are people even getting a lunch break? And those are important, but rest and recovery also can come from the type of work you do. I think one of the things that has also struck me is I'm hearing about just around the type of work that people are doing, many actually shifted what their roles were. We actually redirected many people into different jobs. And that, from a short-term perspective, actually can be exciting. It's something different, but it actually became a new norm. If you think about, we're almost 18 months into the pandemic, many of those people didn't go into work to do those types of roles. And so what I'm hearing now is a lot of people saying, I want to get back to the work that I want to do, because I'm not finding the joy in work in this new role that I had to be redirected into, which was necessary. So there are many, many contributing factors that we have right now. And I think the biggest worry I have is that if we are not purposeful around, yes, rest, but also recovery in terms of thinking about the type of work we're doing, how are we building social connections, how are we looking at those different energy sources that exist and actually creating an environment that creates those as fuel sources rather than fuel sappers, so to speak, I think that we will be in trouble. So, does it mean that we actually just put a pause on any redesign or improvement initiatives? So that we just deliver the care. We can't tell the patients we need a break to stop coming in. They will continue, but we can actually reduce the workload purposefully by perhaps saying the next 3 to 4 months, we're putting a pause on anything new just to create that space. We can also look at the type of work that people are doing and start to have conversations around that. So there are, I think, opportunities for a way forward, but I think it's about also understanding what is it that is contributing to that need. And it isn't always as simple as people working long hours. I know people who haven't had a day off since the beginning of this, and certainly among senior leadership. I think I have a colleague here in BC who I think has had 1 day off since the start of the pandemic. That is big, but it's beyond that. And so as we think about the way forward and how to be purposeful in that, we're going to have to be broader in understanding about what drives energy at work so that we can actually create a new workspace. So I'll stop there, Jen, and see if that answered your question, or perhaps Scott or Jillian have things to add to that.
I mean, maybe I can pick up that thread and actually toss it to you, Scott, because Christina, you were talking about the need to be purposeful. And that is something, and Scott, as you and I have had previous conversations, the military has a history of operations and some different kinds of thinking about what do you do pre, what do you do during, what do you do post in a more purposeful way. So I'm wondering if you can share a little bit of your experience from that perspective, and what's been successful.
Sure. Thanks very much, Jennifer. As a federal employee, I have to start with my standard disclaimer that the views that I'm about to share will be those of Scott Malcolm and not those of the Canadian Armed Forces or the Government of Canada. The other disclaimer that I have to share is that the response to the pandemic sort of fed into one of the strengths of the Canadian Armed Forces. I mean, folks are trained from day one in basic training for sustained operations, so that's how we approached the planning here, whether we go back, even to pre-wave 1 with the planning of the repatriation flights from folks out of Wuhan, China, or into the long-term care facilities, or the vaccine rollout and the numerous other supports that we've provided nationally. And so what does that mean that we're trained for operations? Well, and by identifying it, well, what it does is it allows us to separate it from routine day-to-day operations. So it's signaled right off the bat as something different. Even the fact that I'm wearing this dress right now, which for many of you may not seem like such a big deal, but this is our operational dress. And really, since we've been in the pandemic, the signal to everybody was, hey, we're recognizing that this is a unique time, acknowledging that it's not the normal. And really, it set us up for a number of the other things that we do on operations that we may not do on the standard day-to-day. So what we do on operations is pardon me, create some leadership redundancy. We're reliant on folks that can come in and fill in acting roles behind ourselves. And what that creates is, either short-term reprieve opportunities, whether you call them an R&R, rest and relaxation, or an opportunity to take a week of leave, just to give people either a mental break or a physical break or both. When we go into operations, we go in thinking, what are our measures of success? What are our exit criteria going to be? Again, not something that we would necessarily consider on the day-to-day routine, but it shifts our mentalities. For our missions overseas, we had developed these decompression periods of time. And in fact, we use these for our folks coming out of the long-term care facilities. It was modified, obviously, because quarantines were required, but it was something that we put in place. And so we talk, during those periods of times around our Road to Mental Readiness program, which talks about resiliency, getting a feel for what people experienced and helping to normalize their feelings coming out of that. Specific to our long-term care facility deployment, we had psychological support available for the teams there via Padres and social workers. And then we also have a deliberate use of vacation or leave planning, at the end of the missions. And as I said before, during, with the use of the acting folks. We'll also reinforce things. And again, this is part of the Canadian Armed Forces culture around physical fitness and stressing that importance, even though you're on operations. And I think these are things that, again, are germane to the Canadian Armed Forces. I think there's some things that could be shared across. Now, certainly that's not to say that we haven't burnt people out, because my subordinates would call me out on that. We've still got lots to learn here, and this has been a challenge across the board. I think with the needs-based approach that we've taken, we were able to, shift and utilize other folks, trying to preserve some capabilities. And then the other piece for us is we've been transparent upfront, both within the Canadian Armed Forces and truthfully with the government, about what it is that we could and couldn't provide. And I think building that narrative over time will allow us to carry that narrative forward, hoping to set limits, as Christina said, limits on new initiatives that may be requested of us in order to build that period of recovery for us. So I'll stop there and hand the floor back to you, Jennifer. Thank you.
Thanks, Scott. And maybe we can transition to you, Julian. I mean, Scott talked about the fact that they're doing things that are different than normal, right? Including wearing different uniforms. And obviously the uniforms may be different, but you're sitting in a different space than you would normally be. As you think about compassionate leadership during this time of the pandemic and looking forward and picking up on one of the questions in the chat, what's changed in terms of your leadership approach, or what's changing?
When I think about the term compassionate leadership, there was a phrase that in wave one that was very prevalent in social media. It talked about we're all in the same storm, but not all in the same boat. And when I think about that phrase and think through with our staff didn't experience the pandemic the same. We all lived it, but we experienced it very differently. There are people who had young children who were now working from home, trying to balance young children. There were people who couldn't work from home, but had young children at home that they had to figure out how to care for, because they are people who their job doesn't lend themselves to working from home. We had people who were redeployed into places that were scary. We had some people refuse to be redeployed. They just couldn't manage that. But others did and saw it as a growth and rewarding experience. We had, as Christina said, we've had leaders who have been on for a year And every time they tried to take a day off, something else happened that pulled them back into work. So people's experience, if I think about our physician workforce, we had some who were very busy and some who literally didn't have a lot to do in some of the waves because we canceled a lot of surgeries and procedures. And so their income was substantially impacted. We have staff members whose family members were laid off and lost their job, and they were now called upon to be the breadwinner in the family. So the experience, I think compassionate leadership is understanding that we've all experienced this differently, and our patients have experienced it differently as well. And so when they come, they may not be as patient as they were because they're stressed. Their surgery may have been canceled 2 or 3 times, and they're waiting and they're scared because they're not sure if their cancer has spread while they were waiting. So we need to, there's a compassionate leadership is about understanding that we have had different experiences, and how do we make space for people to be able to share that. And so one of the things that we have, among many other things that we put together in the organization, we did have a care and engagement group of frontline staff who did all kinds of creative things. They would put out a monthly calendar of activities to do and competitions with prizes, and lots of our staff engaged in that. We had photo opportunities where people picked a picture of something that brought them comfort. But one of the neat ones that we've started is a resiliency project where we've asked staff to write, whether that's through poetry or narrative. And we brought in someone to teach people about narrative, because healthcare is a narrative profession. We invite people to tell us their story. We draw alongside them, and we hopefully help improve their story as best we can as care providers. So we've invited our staff to engage in a narrative project where they can share their experience in their words. And we're going to put that together and put that into either an ebook or some kind of a publication for our staff to be able to share the fact that we all had different experiences during the pandemic. And I do believe compassionate leadership is about allowing people to tell their story and share and find their own voice. As I think about recovery, though, it is, I think, about what Christine said. How do we give people space? And how do we make sure that we give people time to recover? For me, I'm somebody who very strongly feels there needs to be boundaries between work and home life. And we lost those boundaries during the pandemic. And as leaders, we need to reestablish those boundaries of, unless it's a crisis, we don't expect people to respond on weekends and nights. We need to put those boundaries back into work. And we also need to give people space and get people away and not expect them to respond, and give them permission to shut off and not respond to emails and not be available by phone, because they do need to unplug. For our political leaders in Ontario, we are looking at an election next spring. And one of the things as a regional influencer, I've really tried to push the fact that there should be not any expectations over the next 2 to 3 months of doing incremental volumes. Let us get back to the volumes we did before, but don't look to do recovery volumes till the fall, when we can slowly ramp up but give people space. And don't expect to start brand new exciting initiatives as in order to have stories to tell for an election, because people we serve need their services recovered. That should be our primary focus over the probably next year to 18 months, is to really put those volumes back, do incremental volumes to serve our public. They're looking for care. That's compassionate leadership, to really say no and learn to say no. And that's sometimes hard, particularly in the political climates. But I think we need to collectively say no to a lot of other major initiatives, and allow people to heal, but allow us to serve the people who are looking to us for care.
Thanks so much, Jillian. I think that's some wise lessons there, and one that feeds in perfectly. This gives me a really nice bridge to a question in the chat for Christina, which was, can you elaborate a little bit more on your comments around pausing QI, particularly if there's, a particular set of partnerships that people are really interested in seeing for the future? So can you talk a little bit more about what you mean?
Yeah, and I think, Jillian, I think you said it just perfectly, actually. It's not about not doing them, you know, and it's not about not valuing them and not about putting them aside and saying they're not going to happen. It is just to say we need time to regroup. And you can't regroup when you're having to do your everyday delivery of care job and be asked to redesign the way you're delivering care at the same time. And so I think, you know, as Julian said, it is literally, I don't think it has to be a long time. I think 3 to 4 months is doable to say, we're just going to give the care that our patients need at this time. And we're just going to put a pause and readjust timelines on the new partnerships, on the new work. The challenge is, I think, balancing that, because as I mentioned, there's different types of energy, and the NHS has a great model called Energy for Change, and you can look it up online. But they talk about 5 different types of energy that exist in the healthcare context. So there's intellectual energy, which is, you know, the energy of using our minds and evidence and all of the things that we often do. There is sense of purpose or spiritual energy, which is, you know, what matters to me and my own values being tied to the work that I do. And it's often, you know, when you think about in healthcare, we have a lot of that sense of purpose. It's delivering care to those patients. It's the physical energy that Scott talked about, just being able to do the work. And that means we need, you know, the right kind of sleep and rest and, you know, eating well and physical activity. There's also psychological energy. And I think, you know, Julian also commented on that, where people didn't feel safe to go into a work environment. That is a significant, in those contexts, a significant energy drainer. And then the last is the social energy, which is that sense of connection. And you know, people have talked about in the COVID environment, that loss of connection with patients because everybody's behind masks, the loss of connection with their colleagues. You know, that social time, those social opportunities have been taken away. And so, you know, it's about the balance, I think, though, is, you know, the new work and the redesign is often a source of energy for people at work. So it's balancing the timing of the restart on that. But those new initiatives, we know quality improvement opportunities to make care better ties to all of those energy sources. But I think if we try to just keep going, and we talk about in a work environment having the right balance between productive energy, meaning high positive energy where you're working hard and delivering the care and getting work done, balanced with what we call comfortable energy, which is low positive energy. You need an optimal balance between the two. We know if you try to be productive for too long without meaningful downtime, you will end up in burnout. And I'm seeing more and more people, we're seeing people changing jobs. The number of job shifts that we're seeing in British Columbia is above average by quite a bit. We're seeing people just deciding to retire and just saying, I'm done. And I think I'm seeing a question from Heather about the Health Human Resource Challenge. We had a Health Human Resource Challenge going into the pandemic. The pandemic is adding to that. And so I think by being purposeful and creating that space so that people can actually come into the new work and it being a positive energy space is going to be really important. So I think the key message, and it's probably a long-winded key message, is it is not about not doing them. It is about saying, let's make sure that we're in the right space to do it well, so it can actually re-engage people in a meaningful way, because that new work, those new partnerships, that new redesign is going to be a critical part of our recovery. It isn't just about the rest, and recovery is purposeful, I think, around those different types of energy. How are we going to create social time? How are we going to, and the social connection back between our patients, back between the people we work with? You know, administrative staff are all alone in their homes. The clinical staff are together, but it looks different. And so it's about looking at both, you know, all of those people who are working in the system and understanding there is no one way. You know, clinically, it looks different than administratively, and we need to be purposeful for all of the people who are critical for us in our system.
Thanks, Christina. And Julian, you looked like you were leaning forward. Am I reading your body language correctly that you'd like to jump in?
I just wanted to add, we just refreshed our strategic plan, and people kind of looked at it and said it's an odd time to do it. But we needed to really look forward, and it did give people some energy to look forward, but we've been very careful to say really little net new. It is about sustaining work that we had started and making sure things that we might have had to pause, slow down, how do we make sure we don't lose some of the momentum? But we also looked, there's parts of the organization that hadn't been substantively impacted by COVID. And they had a different level of energy than other parts that had been substantively impacted by COVID. And so we looked at some of the quality initiatives that they were excited about doing and said, yes, you're not dependent on the people who are actually needing time and needing space in order to move this forward. So yes, we will include that as part of our strategic priorities for this year, but it was really looking at capacity, and not everybody is in the same place of capacity, and it's appreciating that. And sometimes when we start initiatives, we aren't always appreciating the other people in our organization that may need to help to move this forward, and appreciating you may have capacity, but they may not. And so I think it's really being sensitive to that idea that other people have experienced it differently. And so we're very careful about what we included based on the capacity of all the people that needed to move that initiative forward before we said, yes, let's move forward with it. So I think that's the other thing to think about.
Yeah, such a good reminder, Jillian, that one size definitely does not fit all right now. We are in very different places. Scott.
Just to pick up on the same theme, we heard from one of our trades, our medical technicians, for example, that, from a retention perspective for them, it was important to see, their scopes of practice enhanced. So in many ways, this aligns with our recovery efforts, in order to offload and shift the burden of work and the backlog. So in my view, as both Christina and Jillian have said, the goal is to really hear what the folks on the ground are saying to avoid, it's not the time for the top-down initiatives, but if there's folks with energy and it aligns with a recovery, in my view, those are the things that in the military we're looking to move out on right now, and minimizing any of the top-down things that we, might think in the ultimate wisdom of Ottawa are great ideas, but, the folks on the ground who are living it say, hey, let's just give us a little bit of space.
Yeah, it's been so interesting because obviously our organization works with people across the country in very different parts of the health sector. And we've certainly seen that variability as well, that there are some folks who are champing at the bit, right? Really ready to move. And then others who are saying, actually, not right now. We need a little bit of a pause. So it is that flexibility for sure. And maybe picking up on that, and one of the other questions that was raised in the chat, and Scott, I'll toss this one back to you because you talked about scopes of practice and, some creative models of care. And that was one of the questions. We had some challenges with health human resources capacity before the pandemic, never mind now. Looking forward, how do we think differently? How do we think about new models of care, different types of approaches?
Yeah, thanks, Jennifer. I never thought that health human resources would get me excited, but all the credit to Dr. Ivy Bergeau and Dr. Gail Tomlin Murphy, who have converted me onto the concept of needs-based health workforce planning. Admittedly, it's not a new concept. It's been around, as I understand, for decades. And frankly, it's not completely easy to do, which is why folks haven't taken it upon themselves. But we really need to move away from this concept of, a clinician and population ratio models, which are easy. Well, if you have a pod of X number of patients, then you get X number of clinicians. Well, that changes over time, and the needs shift, and that model doesn't work where, your needs-based one says, and I think this will align with some of what we've heard from Jillian and Christina. What are the programs and services that we need to deliver today? Those must-dos. Obviously, recognizing that some we can't or shouldn't. And then how frequently do you need them? And then what are the clinical skills required to deliver them? And then how do we look at the least scarce resources in order to, to shift that burden of work, perhaps from from your most scarce, whether it's, your specialty surgeon or your specialty nurse or whichever clinician you want to speak of, your OTs, your PTs. Are we making best use of the limited resources? And I feel that unless we're going to be able to signal to folks right now that are contemplating leaving, and for those that have left, or for those that are looking in saying, hey, do I want to wade into the healthcare field, they're going to need to see that something is occurring now, something concrete and meaningful, that we're looking to find, a balance between, a balance between the tasks asked of our clinicians and the health workforce that's assigned to accomplish to them.
Excellent. Yeah. And I think, maybe this feeds us into the next sort of conversation as well. Again, looking forward, there was I'm going to paraphrase it, a question asked in the chat about, is it enough to think about recovery? Or do we need to think more broadly in terms of collective actions towards new ways of life that take into account not just what's happening within the health sector, although Scott, you just spoke eloquently about the need to really consider a broad set of questions in the health sector, but also all of the things that are happening in society around us, many of which we've already spoken about on this call. So where are all of your heads at in terms of, how can we think broadly in terms of that collective work towards where we want to go? Christina, you look poised. Do you want to jump in?
I have lots of thoughts. I agree. I think there are many opportunities coming out of this. And I think the biggest one is around equity, where the issues on equity were so exposed. And in the early days of the pandemic, I thought, oh my gosh, we're finally, it's the same, on population health or health promotion or public health. We've always known it's important, but it takes something big for it to remind us, which it shouldn't. And I think the same on equity. We've known for years the consequences of inequity on the health of the population, and they're unacceptable. We all agree they're unacceptable, and yet it is never prioritized politically that I've seen. And I think, and again, these are my opinions, personal opinions that I'm sharing here, but I thought, oh, this is amazing. We're finally going to get on equity. This is fantastic. And I'm already seeing that interest wane. And I find that sad, actually, because I do think it does go beyond recovery. And it has to be, what have we learned? The attention we're seeing on the long-term care sector right now is fantastic. Let's hope that stays, because we need it to stay, that focused attention. But, between long-term care and equity, I think are the greatest opportunities that we have. And I actually think that can be fuel as part of the recovery done well. But I think in order to actually embrace the complexity and the challenges and the difficult work ahead, we have to come out well out of this pandemic. And if we bypass that, because I think we're our biggest enemies too, especially I think, the people who are on this call care about health, they care about quality. And so we often we get excited and want to bring change to the system. And so we also have to be patient and remember that we can't get too excited and move too quickly, because it's just like any kind of improvement project. We say you have to do the groundwork before you start making the changes around the engagement and co-creation. And it's very easy. And I think as leaders, there's another question about leadership in there as well. I think as leaders, we create the context in which the system works. And it's the political leaders, but it's the leaders of the organizations, it's people like Scott and Julian who will determine what the expectations are and the pacing. And so I think we have to just take the deep breath and know that in the big picture, 3 to 4 months of actually giving people time isn't big. It's actually a very quick window of time. But if we skip that because of either political pressures, because there's elections coming, or just wanting to get caught up around commitments, or how are we doing, pay increases, and how are we holding people accountable around performance? Can we change that? in this unique time, right? And how are we actually doing that? So I think I probably circled around, but I do think we as leaders have a disproportionate influence. We know that. And now is the time for us to actually really think about the pacing well, and then to look at absolutely those areas. And I think equity, if we miss this opportunity to truly get into equity, I'll be very sad, I think.
Absolutely, me too. Jillian, absolutely, jump in.
If I could, I very much agree, Christina, that equity, but inequity in so many different areas. I think what was very much highlighted during the pandemic is the difference between urban and rural, the difference between digital access and non-digital access, both for healthcare and for education, and even just accessing information. Almost everything was online, and if you didn't actually have that access, you didn't have that information. Something very simple. I go to a church in London. 15% of the sort of older people don't have internet at home, and so very difficult for them to sort of access the information that they had. We serve in our organization some very marginalized communities living with complex mental illness, homeless population, etc. Digital equity, access to food, when all this sort of the places that offered free lunches and dinners closed down because of social isolation, and particularly in wave one. So I think that's a huge appreciation of the disparity of the social determinants of health that are such an important part. But the other thing for me that became very, very evident as at least in Ontario, they were looking for hospitals to deploy staff into long-term care and serve in assessment centres and help out in the vaccination. Hospital staff and community staff were working side by each, but the disparity of income is not insignificant. When you look at the difference between a community-based RN and a hospital-based RN is not insignificant. And that disparity is a challenge when you're trying to actually transform the system. So what we have talked about in the regional discussion is restoration, recovery, and transformation need to actually come together. We need to look at restoring, we need to look at recovery, but we also need to look at not just building back the way we always did it before. We need to look at doing it differently. And so there's that piece that we don't want to lose. But how do we do that in a way that is thoughtful and considering all the people that we serve and all the people that work with the system together from an equity lens as well. So it is going to be a challenge as leaders because some things I can change, but there's lots of things that I can't change without sort of the political and the people from the ministry to be able to change some of the policies. So I think it's going to take all of us, and I'm hoping, as Christina said, long-term care remains a focus, and I hope it's not just a focus on compliance, but it's a focus on actually changing the fundamental problems with long-term care, not just actually putting more rules in place and more compliance inspectors. That won't solve the problem. So I do worry that sometimes we pick the easy fix and not the hard work that needs to be done to actually fundamentally change the system.
Thanks, Jillian. And it's killing me, but I'm looking at the clock and I'm realizing we're down to our lightning last round for an opportunity for one last insight from everyone. And maybe I can tie in, Jillian, that last comment of yours and an earlier question, which is, if you think about that transformation that we need to see, what's a leadership practice or a leadership change, a leadership focus that you think we really need to all think about as we're moving into that, not are we there yet stage, as you said at the beginning, Christina, but what comes next? Scott, do you want to start us off?
Sure, that's a lofty question.
For a lightning round, why not?
Sure. So, I mean, I think I've got two thoughts on this. One more perhaps philosophical than the other. I'll start with the philosophical because what I'm hearing is really the need for us to recognize our healthcare system as a complex adaptive system, meaning we have to be comfortable to allow innovation to occur and loosen the reins on trying to control it. I think we as leaders have to foster that innovation. And I remain hopeful, as well as Christina and Julian said, that the long-term care facility remains an important agenda item. And there is some momentum there. So how do we help foster it and move that along? And I think more on the concrete side from our perspective is, how do we move from a healthcare system that's fairly paternalistic in nature in many ways, and one that moves through patient-centered into patient-partnered care. And I think having that focus, can help to address the equity issue by actually having those stakeholders, having those voices around the table to hear their needs. And I hope that brings us back to the idea of the compassionate leadership that Jillian spoke to hear the needs of all the stakeholders, and then take concrete action to do something with that information.
Thanks so much, Scott. Jillian, I think that was a baton pass to you.
Thank you. Two things I think are going to be really important. I think we need to face the future as leaders with humility. Both cultural humility to really understand how do we truly serve the diverse communities in a way that is meaningful and sensitive to them, and how do we make an inclusive work environment and understand what that looks like. So I think humility is going to be a mark of leadership that needs to go forward. The second one, as Scott alluded to, is the leading in ambiguity. It's how do we set the why and the what, but let others who are closer to the issue do the how, and let go of that a bit as leaders in all different parts of leadership, and allow the how to emerge. The other thing about humility is what I would call system humility. Is I think what we came to realize during the pandemic is, if you're a hospital leader but have never worked in long-term care or in the community, you really don't understand it, and vice versa. And so how do we have system humility and listen to our partners well as we actually try to redesign the system, but understand what we don't know about the other sectors and come to the table as true humble partners, bringing the best of what we have, but allowing others to do the same.
Thank you so much, Jillian. I think that's so important. Christina, round us home.
I have to absolutely agree with both Scott and Jillian on the issues that they brought forward. And I think in particular, the humility piece, I think in so many areas is just fundamental. But I do think, we need to get better at pacing, and we do need to get better, not just around the pandemic, but the access we have to information and the speed at which we get to know things and the pressure to respond very quickly is very high. The expectations of public, the expectations of the politicians, the expectations, are high. The expectations of our staff are high. And I think we have to moderate that to make it manageable. And that doesn't mean not being aspirational. It just means, it's not just about having the financial resources. People often talk about, work off the side of the desk and all of these extra things because we don't have the money to do what we have to do. But there are other resources that we tap into individuals. It's the intellectual energy, it's the social, it's all of those other pieces. And I think we have to be able to be okay. And I think Jillian said this at one point, with saying no, or saying we're going to take longer to get this done, or we may defer, but it doesn't mean that we aren't going to do it. And I think just the amount of opportunity for improvement is so high. But we have major issues ahead of us. One is coming out of this pandemic well, but the other is the Indigenous specific racism in our system. And that is going to be front and center and needs to be front and center as well. And our ongoing opioid crisis. We have 2 public health emergencies, and the number of deaths coming out of the opioid crisis are continue, at least in British Columbia, to far exceed the impact, on the COVID deaths. And we have much to do in our system in addition to delivering high quality care each day. So I think, you know, for leaders, it's about managing that complexity and the pacing and all of that. So I don't have answers on how to do it well. And I think that's where I'm going to show some humility, but I think we can, we do have an opportunity to work in a different way coming out of this as well.
Thanks so much, Christina, and huge thanks to all of our panel members. If we were in a big room, there would be a roar of applause right now, I know, to thank you for all of the insights you shared today. And the ability, you know, so many people have been so deeply affected during the pandemic, and we owe it to everyone who's been affected to be purposeful going forward and to live in that all teach, all learn space, to be humble about what we know and how we can work towards that transformation, towards the excellence in care that we all want and we all want to see and be part of. So huge thank you. And now I'm going to turn it over to our participants. If we can get you to answer 2 quick polling questions, it just helps us to make sure that we're putting together learning opportunities and sharing opportunities that are helpful for all of us, and that will allow us all to get to those spaces as we go ahead. Thank you, everyone. Really appreciate it. And hopefully everyone has a chance to get the restoration and renewal that we all each need over the next while. Thanks very much.